scheduling. This one is very basic in terms of the first 12 are all are looking at vehicles and topical steroids. So the students that have come before you have told me that this is the most valuable information they have going into derm. So pay good attention to it, and before you do your derm rotation, is it required?
No.
Well, a lot of students do it though. Okay. So if you're going to do a derm, look this over, because they've told me that off the bat they're expected to know these things. Okay. All right. So we're going to spend some time the first page, and then on several of the slides we're going to look at the different vehicles. So there's lots of different forms to be able to put something on topically. You've got creams, ointments, lotions, gels, tapes. They all depend on where you want to put them. So you will not use all vehicles on all types of skin. Okay? So that's one of the important things to look through as we go through, is that some vehicles are better placed on certain parts of the body. It also goes to the amount of area you have to cover. So some things we're never going to use over large spaces. Some areas we're never going to use, or going to very rarely use them on very thin skin. So on infants or in intertriginous zones, we would not use them. Some things that we do in vehicles, we can increase the potency of a drug. And sometimes that's important. Sometimes we want to increase the hydration. When we get to psoriasis, we're going to talk a lot about that, because those plaques are very hypertrophic. It's very hard to get drug through them. So we'll use emollients and things that will hydrate the skin in order to enhance the drugs getting through. So we'll use multiple techniques using these products. So let's talk about the different vehicles. So the first one we'll talk about are the, does this one work? Okay. So ointments. What do you know about ointments? They're greasy. What? I can't hear you.
She said water insoluble.
Water insoluble, okay. So where would you most likely use them? Thick skin, so in psoriasis we'll use these. What else? Pardon?
Maybe areas that you would use a lot to stay on better?
Okay, when you put an ointment on, it's going to stay put for the most part. Okay, it's not the same with a cream or a lotion. So that is important. If you want something to stay in an area and drive a drug into the skin, keep it hydrated. Hydration will go a long way in getting drug into the skin. So ointments, here's a different type. So at the bottom you see that big yellow clump, that's lanolin, that's a common one. Lanolin, where's lanolin come from? Sheep. So if you have ever felt wool, that greasy part of it is lanolin. It's an excellent hydrator. Right next to it is white petrolatum. So those two are very common bases that are used when we make ointments. You'll see the A&D ointment, which is really common for kids or as a skin protectant, is a combination of those. You've got lanolin and petrolatum. So we use that, put them on a baby's bottom to protect them from the urine sitting there, or a wet diaper. Zinc oxide, another one. I don't know if you ever covered your nose, that's what they did to us when we were kids. Everybody had white noses in the summer, was the zinc oxide. Okay. So pharmaceutically, the reason why ointments will stay where they're supposed to is that they are water in oil. So the water is dispersed in the oil. Now we can have oil in water, and I'll show you that in a little bit. So the water droplets are spread throughout. So if you notice butter, if butter ever sits in a certain way, you'll sometimes see water come to the top of it. You'll get a little moisture over it. That's because butter, that's what butter is. It's a water and oil, so sometimes that water will leach out just a little bit. That shows you. So emulsions can be water and oil or oil and water. So as pharmacists, we learn how to make both. And you use them for different reasons. So you see butter there is a water and oil, but like mayonnaise, milk is a oil and water. So you have fat droplets dispersed through a water base. Whereas in the water and oil, it's an oil base and you're dispersing water through it. So we use them for different things. And we almost always put an emulsifier in there. So what's an emulsifier do? It actually will keep it together in an emulsified state. And then we use agitation often just to put them back in. So oil and water, your salad dressings, mayonnaise, and milk would be food. And then the cream, like whipped cream. So the other day, I was standing in the kitchen, and I heard this noise, and I turned around, and here's Dr. Britton with a can of whipped cream squirting in his mouth. I'm like, are you 14? He's stressed. She said he's stressed. So I bought myself a can and put my name on it.
You put Dr. Wisconsin on it?
Of course. Because that's when he calls me home. Okay, wait a minute. All right, so these are water and oils. Let's see what else we got here. Okay. Excellent lubricants. They will facilitate heat. They are occlusive in nature, so you would never put these on a burn. It'll just make it worse, so the heat won't escape. Okay, so you don't put it on like sunburns or a thermal burn. So they're semi-occlusive in nature. They prevent water loss. So that's why we like to put them on very hypertrophic skin, because it will keep any moisture you've got in there already there. So we would put it on after someone had bathed or had hydrated themselves in some ways, either an emollient or washing, scrubbing with water. Most potent. We can increase the potency of steroids by putting them in ointments, because they'll adhere, they'll stick, and they'll stay longer, and they'll drive into the skin longer. You don't want to put them on in hairy areas. Why is that?
Will they be held like above the skin because they're so thick?
Well, sometimes, yes, some of it's just getting it down to the site of application. What would be the other? Folliculitis. So if you cover up those hair follicles, eventually they could become infected and you'll get a folliculitis. So next slide shows you that. So that man has a folliculitis. It may not be due to a drug, but it can show you how painful and widespread it can be. In that bottom is a psoriasis plaque, fairly mild one, but you can see how hyperkeratotic it is. So whenever we're going to put medicine on that, we always are going to put an emollient on first, and then the drug vehicles that we use are often ointments on top of that. You're not going to put them in intertriginous zones. The one at the top that's kind of gray shows you, it'll macerate. Remember when we did the toes in our athlete's feet? We had water trapped between toes. Well, it's the same kind of thing. You trap water and moisture in an area for long enough, under the arms, in between the folds of the leg and the trunk, under the neck. If you've got enough skin folds, if you've got obese patients, they've got skin folds that are hanging over each other and you don't get a lot of air, then eventually those areas will macerate, or you'll get yeast infections. So you trap moisture in, and whatever's there will grow. This is a really good little picture of somebody put together. If you look on the very far end, you see Vaseline, which is 100% no water in it. and then water on the other end. Then look at the different product types in the middle. Ointment, so you've got mostly oil, some water, and they will have a range. You can certainly make ointments that have more water parts. Creams are going to be close to 50%, 50 water, 50 oil. And lotions, well, you can tell because when we do lotions, we usually use those on our skin. They spread well. Why else do we use them? Why would we use a lotion over an ointment for our hand cream? Pardon?
Absorbs quicker, so
So it's not
It's not so much it absorbs quicker,
not greasy.
it evaporates. So the water evaporates. Oil never evaporates. Water will evaporate. So the higher the water content of a vehicle, the faster it'll evaporate. So lotions evaporate faster than creams. Creams do it faster than ointments. So under the second section there on page 2, they are semi-solid emulsions. They're water and oil. Okay. You can wash them off. Can you wash off petrolatum? Not very easily. It'll resist it. So washes easily. Good lubricating qualities. I'll show you some that you should keep in mind if you have to recommend them. They vanish into the skin, so people like that. Do ointments vanish into the skin? No, they look like you're just going in, I don't even know what to say they look like, except they will look, you look shiny, don't you? Generally less potent than ointments, okay? They won't drive the drug into the skin as to the same extent that a ointment will. Okay, so exudative, so this is one thing to keep in mind. Anything that's weepy will do better with the cream because it will dry it. Doesn't really look like you put that on to dry it, it will because of the water content. You can use these in intertriginous zones because they will, because of its drying effect, not an occlusive. Here are some excellent type of creams. I'll show them to you again later on. Some of the students in the first year class asked me to put names to these after they got out. So these are really good. I would stand behind any of these. They're expensive though. They come in pound jars. You can get them in smaller. Urea 20%, very good. Hyperkeratotic, big thick psoriasis plaques. This is what we would use, 20% urea. Cetaphil, excellent, excellent moisturizer. So when we get into areas where we've got like a lot of itching, where we've got dermatoses, and we want to cover big areas, Cetaphil is really good. Aquaphor and Eucerin, same thing. We would use these in pharmacy compounding as a base if we needed to. So these are really good products. Okay, so let's see if we've covered all that. Okay, lotions. So lotions have even more water in them, and solutions have even more water in them. So they are meant, lotions will hold a form. So if you look up there by that Vanna cream, it will hold, if you put it down, it'll hold, but it is still much more higher water content. So if you have to cover large areas, lotions are a way to go. They can go into hairy areas, so that makes it better. You can put them in on the scalp, which sometimes is hard to get drug down to the scalp, so they come up with other forms to do that. They penetrate easily and they don't leave a lot of residue, so hairy areas, they're an advantage, especially scalp. Aerosols, well, solutions sometimes, some other products that would be similar would be sprays. So sprays, again, if you have to cover a big area, are an advantage. The foams or the mousses are gases that disperse into a liquid. They are very dependent on the applicator that they are placed into. So they're very expensive. Like that clobetasol there is about $300 a can. retail. So these are really good, like for if you've got scalp psoriasis or seborrheic dermatitis that you are trying to treat, this is an excellent product because it penetrates very well, it doesn't leave a residue, and it evaporates quickly. And then you have the shampoos. So like dandruff, we would use a medicated shampoo. So they're very easily applied and easily rinsed off. So we could put the same drug in every one of these vehicles and get a different response. We could get a response to where we get nothing. The patient doesn't respond at all. We can put it in a different vehicle and we get excellent response. So efficacy of the drug will be affected by what vehicle it has been placed in. So you could have the right drug, wrong vehicle, and you won't get the treatment effect that you want. Let's see. Gels. So gels, the difference with gels is that they are in an alcohol base, so they really are meant to evaporate quickly. So that they also pretty much disappear. These would be drugs that you would put in areas where you didn't necessarily, where you wanted it to evaporate quickly. So what did we use Voltaren for? Osteoarthritis. Okay, remember we used some big areas with those, like knees, was one, and we covered a lot of space. So that would be one where we would want them to evaporate. That clindamycin gel is often used for acne, so we're going to put it on the face. So we want to be able to put makeup on over it. Then we would use that. The mineral ice, so for joints, again, same type of thing with the Voltaren. The one in the bottom is a contraceptive gel. So the woman's putting it into a diaphragm. We want it to stay put. So gels maintain a pretty good shape. But when they hit contact with usually body heat, they kind of liquefy. So their spreadability is very good, and their evaporation is the best of any of the different vehicles. But because they have alcohol in them, they will burn like fire if you put it on an abraded area, broken skin, fissures in the skin. So you want to be really careful not to use an alcohol base when you are choosing a product. Very helpful for that very last bullet, oozing lesions, because they evaporate. But you have to really make sure there's no broken skin. Know this chart. It's very helpful. It's really good. They have summarized it beautifully. Because they've given you down the left-hand column is the different vehicle, and then for each of the different areas, they have told you what is best. So if you look at hairy areas, you see lotion and foam as the best. If you look at hyperkeratotic lesions, ointment's the best. If you look at the palms and the soles, again, ointment's going to be best, hyperkeratotic area. Macerated lesions, the majority, as long as you stay away from ointments, usually are going to work. Infected area, solution, again, because it dries quickly. Questions about those? This is a video, I won't show it in class, but you can watch it. This guy, he's a pharmacist, but he is so funny. He really is a cutie. And it's short, it's only 4 minutes, but it's all about how to, it's geared to patients about how to use steroid cream. Some to pharmacists as well, but he's pretty entertaining and he keeps a really good speed, so you never get bored. Very good practical. He talks about how to dose, like if you get if a patient received a instructions that says apply thinly. What does that mean? That is a relative term. I know we do it, but I don't know what the patients interpret it however they want. But he goes over how many fingertips, he uses the fingertip as a unit of measure, which is fine. And then he'll tell you one fingertip will cover so much surface area. So if you're trying to figure out how much am I going to prescribe in terms of amount, it's helpful. So I would definitely recommend watching him. He must do a lot of these because he had all kinds of different ones pop up. And the funny thing he does at the end is he does his own outtakes. At the very end, they're really cute. So everything he messed up on, he puts in there. Occlusive dressings. So sometimes we want to really increase or enhance the absorption of a drug. So we can use an occlusive dressing. So there we're trying to keep out any evaporation at all. And so this shows you a homemade one. Pardon? Oh. So it's got, so on the left-hand side he's got a gauze, and they've probably got a steroid cream under that, and they've wrapped him in saran wrap. You can get more elegant products there on the right-hand side. So occlusion is only when you really are wanting to enhance the absorption of something. You can, I think I put it down there, it's like 10 to 100-fold for steroids, that if you put an occlusive dressing over them in terms of increasing the amount that is absorbed. So you often used overnight. You're not going to put it in on a thin-skinned area because you can cause systemic toxicity. Irritation, folliculitis, infection can occur. So we don't usually keep them on it all the time. Have y'all had dressings yet? You done? Okay. Well, I bet we do it this time. You must have a wound. Wound care and wound dressings. Okay. Any question on vehicles? I can guarantee I will ask you. Be sure you become familiar with what I have in the handout about them. Let's look at the clinical use of steroids. Very, very common. If you're in dermatology, these are the basics of your treatment. So they use a lot of them, and there are a lot of different forms and a lot of different strengths. So we're going to talk about those. So anytime you've got inflammatory, pruritic, hyperplastic, autoimmune type skin reactions, then steroids are the drugs that you're going to use. When are they contraindicated? Be sure you know these. You'll know you've done wrong because as soon as you put them on these and can't keep doing it, they'll get worse. Okay? Acne may, if you have a real inflamed cystic acne and you use it, it will respond, but as soon as you take the steroid away, it will get much worse. It will flare. It's a rebound effect. Scabies. Warts. Warts are viral. The steroids don't do anything for them except knock down the things that are in their way. Kills off the bugs around them that might attack them, or it suppresses the immune system around them that would attack them. So warts don't do well. Fungal infections, we talked about this. If you put steroids on a fungal infection, it will get worse in no time. And then the viral goes along with what we said with warts. Now, there are some times, and we talked about this when we talked about vaginitis, is that sometimes you can, if you've got a real inflammatory process, along with like a fungal infection for very short periods of time, to get the inflammation under control and increase the comfort of the patient, you can mix a steroid with another active ingredient. Okay? And that's appropriate because you're treating the underlying problem, which is the fungal infection. All right. Success to using topical therapies. One, correct diagnosis. That goes for everything we do. Have you got the right thing? What lesion are you treating? Is it hyperkeratotic? Is it oozing? Is it abraded? Is there a disruption of the dermal layer? The correct medication. Again, these are all apply to many things. The vehicle. So this I've already alluded to. Correct medication, wrong vehicle, you don't get the effect you want. So here would be an example. Corticosteroid gel on the hands that are eczematous or fissures. So pain goes up because of the alcohol. The other would be treating a moist lesion with an ointment. Well, that'll just make it worse, and then you get a folliculitis. So two small examples. The method used to apply the medication. So here this talks about, this is going towards penetration. For the most of the time, we would like a skin to be hydrated. So after somebody gets out of a bath would be a common time we'd tell them to apply a topical therapy. Occlusive dressings. Absorption increases by a factor of 10. So you have to be careful, you may not want that. Site of application. So it will vary, the way that you can get a drug into the body will vary based on how thick that skin is. So putting a lotion on a heel of a foot, think about that, that's really hyperkeratotic, is it going to do much? No. So keeping in mind where you're putting it and what you've chosen. Okay, next page. So these are factors that affect the absorption of a steroid. Why would we worry? Why do we care about that? It's toxicity. If you use a potent enough steroid for long enough, you will get systemic effects, you'll suppress the adrenal axis, and you will get all the side effects, and I'll show you some of them as we go through from long-term use. So if the dermal layer has been disrupted, so if it's inflamed, then the drug's going to go through faster. There's not much to stop it or slow it down. If you've got desquamation, so if you've got an abrasion, it will do it. The patient's age. So the younger the patient, the thinner their skin is. Okay? So babies in particular. And we'll use less dose. We'll use the same drug, but we're going to use a whole lot less in them than we would in an adult. Your elderly also have thinner skin. So the two age ranges are going to be have a thinner stratum. The vehicle used, we've talked about. Use of occlusive dressings, again, absorption tenfold. The area of the body that you apply it. If you look down at the bottom, it's probably a little bit easier. So the thinner the dermis, epidermis, faster it goes through. Thicker, slower it goes through. So at the bottom, sole of the foot, this is the percent of drug that's absorbed. So it's from the least at the top, the sole of the foot, less than 1%, up to the genitalia, 42%. So look at things more common. Forearm, about 1%, scalp, 3.5%, forehead, 6%. You're not that far apart, but the dermal layer is different thickness. So that's why when we're putting things on the skin, we use the very least amount on the face, okay, versus another part of the body. Okay. Questions about those? Okay, potency. What is potency? Not so much. Goes to effect. Some of concentration plays in there. So, potency is how much drug does it require to get an effect. Okay. Efficacy is the response you get when you give a drug. Drugs can be, if given in equal potent, can produce the same efficacy. Okay. So if potency is the amount of drug required to produce a certain response, which of those drugs is the most potent? One. If you are looking straight across, let's look at where one, can you see my mouse? Okay. If you look at where one is here, let's say here, it is you've got response on this side, you've got the log of the drug concentration down here. So as you go forward, the drug concentration gets higher. So this, at this level, for this response, one hits it first. Takes a little bit more of 2 to get there, more of 3, more of 4 if you keep coming down, right? Okay, so 1 is the most potent. Which one is the most effective?
3.
You know, 2 and 3 are pretty hard on this one to tell. But here, the response, even though it takes different doses to get there, they're equally effective if you use the right equal potent dose. Okay? So just because a drug is more potent doesn't mean that it is more effective. They are not synonymous. People use them that way, but they are not. Because I can just give more drug and get the effect. Let's try it again. Response on the y-axis, x-axis is increasing drug dose. So you've got 3 drugs, so look at pick out where, like a response. So at 50%, this drug is the most potent, least amount of drug. But I can get the same effect, I just have to get more drug of drug C, or the dashed line. Okay? Look at this one. Because with painkillers, it's something we think about. So what about potency with these? Which drug is most potent? Hydromorphone. Which is most effective? Hydromorphone is by this. You see, aspirin is pretty much out here. It really has a very poor analgesia compared to these 3. Now, what about the slope of those lines? Where is the difference? And what would a slope tell us?
Oh, it changes based on concentration.
How much it changes. So with hydromorphone, it doesn't take much difference in dose to get a bigger effect, right? But it does with codeine. Okay. The slope of the line is less steep. So it would take a little bit more dose of hydrocodone or codeine to get an increase in effect. This is the one I gave you in the very first module. Same kind of thing. It might be a little easier because they've drawn all the lines. So they're looking at a 50% response rate with 4 different drugs, and they're showing them that potency goes this way because of the amount of drug it takes to get an effect. So kind of keep that in mind because people will not use those terms correctly, and sometimes they get confusing. So I hear providers use it all the time. This is a more potent drug. I want to take it because it's stronger. It's more potent. Well, unless there's no other drug that will reach the response it doesn't matter. Okay. So in terms of, there are 7 classes of topical steroids. 1 is the most potent, and 7 is the least. And there's 1 out of almost every group that I want you to know as an example. So 7 you know because it's hydrocortisone. You can buy it over the counter. 1% hydrocortisone is the group 7, the least potent. Group 1, clobetasol being probably the best in that group, 1,000 times more potent than hydrocortisone. So it doesn't take much. Increases in concentration sometimes will affect potency. You'll see that on the next page. You'll see the same drug listed in different categories based on strength. Occlusive dressings. Increase potency by 100-fold. Now we talked about 10-fold in terms of absorption. Here it's 100-fold in terms of potency. So if you're going to use an occlusive dressing over a very high potency drug, you better know what you're doing and how long you're going to do it. Because you can suppress their adrenal axis very easily in a very short period of time. And then ointment preparations usually are more potent than creams or lotions. Again, because more drug will enter in. The paragraph at the bottom and the paragraph on the front, on the next page, are the same. I moved it off one page and forgot to delete it. So if you look at the next page, these give you those groupings. Super high potency is group 1. You need to know that clobetasol is the representative drug out of that group. High potency for group 2, you need to know how long. It's very common, it's been around forever. It's very, very effective steroid. Of the high potency, I want you to know the triamcinolone 0.5%. And in medium potency, I want you to know the triamcinolone, but look at the difference. You've got a difference in strength, 0.1% versus 0.5%. There's not that many lower medium potencies for group 5, so we're going to skip down to low potency for group 6. The fluocinolone, because we're going to use that shampoo and solution a lot on the scalp. And then the least potent is the hydrocortisone. All of those are in your objectives except for the group 2, the Halog. Be able to identify those. I will ask you questions off those, and I will use specifically the names. Okay. All right. So how do you choose? A lot of it will depend on what are you treating, how big is it, how bad is it, what's the age of the kid, how long are you going to have to use it. All of those will go in. So it's best to start with the lowest potency that is recommended for a condition. The super high are used for the most severe of the dermatoses. Not in the skin, not in the intertriginal spaces. However, in autoimmune diseases, you may find them in those areas because it's the only thing that will arrest the immune response. If you go down to lower potency, those might be ones where you would get more on the face or the genital area for treatment. And then the lowest are going to be if you have to cover large areas or you're dealing with children. You're going to use those lowest strengths. We'll pick this back up and you'll see this information again. Okay, principles for appropriate use. This section's important. So just like we did in, we do this with steroids a lot. So when we are going to give someone a steroid blast or burst in asthma, do we start low and go high, or we do the opposite? Steroids, we usually start high, get things under control, and then we back off. You see it over and over and over again. When we do a steroid taper, we're always giving them enough to control, and then we taper them off so that the adrenal axis can recover. So we do the same thing with topicals. We start with maybe a higher potency or more frequent, and then we'll back off to control, to maintain it. So control and maintenance. Maintenance may be that we take it down to where we only have to do it a couple of times a week. So we'll decrease frequency. Or we'll use a lower preparation, or both. Frequency, topical steroids, no more than twice a day, never ever. You'll see most of the time it's once a day, twice a day. Using it more often does not increase the effectiveness, but it increases the toxicity greatly. Okay, administration. We're always we'll teach the patients to rub it in thoroughly. We'll also recommend wash your hands. We'll tell the parents that if they're going to apply it to a kid, wash your hands because they will absorb them through their fingers. So we want them to rub it in. We want the skin to be moist. We'll get more penetration that way. Again, we're going to think long and hard if we've got an occluded area, a thin-skinned area, or a young child, or an old person, what steroid potency we're going to use. Patients, very last sentence, patients who use the highest potency for longer than 2 weeks then become vulnerable to the systemic effects. Duration on the next page. Super high potency, so that's like clobetasol or how long? Should not exceed 3 weeks. Once you get past that, then their risk of side effects goes up quite a bit. Talks about intermittent, the twice a week for maintaining long term, and we'll see that as we go through the different discussions. Is moving people down to this lowest frequency that will maintain the treatment. We do taper, just like if we're going to use them long term, and some of these dermatoses are so difficult to control that once we do get them under control, and we can eventually taper them off. Now sometimes people are going to be treated for 6 or 12 months before we ever start taking them off. So just like we do with orals, the same principle applies as we're going to taper it. Otherwise, they will rebound. The condition will come back and it will be worse. It'll look worse. So rebound in order to avoid a taper. If you've been on really high doses, the other reason to do that is to allow the axis to recover. High potency. Children, don't use it on the face. Don't use a high potency on the face for anybody. We should not do that. If a dermatologist does it, that's a different thing. Once a day with the high dose, not longer than 2 weeks. Now some conditions will require this. This is like in general type stuff. You'll see down there for the doses for kids, significantly less. They have a smaller body surface area, so we use less dose. And here's some just general guidelines. Infants, about 20% of an adult dose. Kids, about 40% of adult dose. Adolescents, 2/3 of an adult dose. Pregnancy, you have to be really careful because they will absorb, and whatever they absorb, the baby will also get. So using the lowest potency possible. If you have to use a higher potency and you use it longer, then you're going to monitor fetal growth. Remember in asthma, we talked about one of the problems in using inhaled steroids in asthma was what? It was growth. It was growth velocity. They eventually achieved their final growth height, but it was at a slower rate. Okay, so it's the same principle here. So they may just not grow as fast. Since there's not data on topical steroids in breast milk, then you'll have to use judgment. And we're not going to apply them to the nipples. So warn women, because they can get that hydrocortisone over the counter. If they put it on there and the baby nurses, they'll get it. They'll absorb all of that. Questions about those? I'm going to finish up the steroids, which is through page 12, and then we'll take a break. Okay, so the topical side effects of steroids is different than the systemic. So they can get the systemic. A higher potency, long term, they can get it. But there are other skin side effects that they can get. On the test, you will have pictures of these effects, and you will have to identify them. Did Professor Hughes already tell you that about different? Okay, so this test will have lots of pictures on it. So be sure you've looked over those pictures and can identify the side effects. Okay. So, steroids thin skin. So you can see it two different ways. Epidermal, you see that if there's a thinning or there's actually an atrophy of the skin. If you identify it early enough, then they can recover. If you go long term, sometimes it's not reversible. Telangiectasia also will occur. These are often not reversible, and they show up on the face. They can be on other parts of the body as well, but this one would be more cosmetically not pleasing. The stria, so these are like stretch marks. So this one's in the on the arm. You'll see down there popliteal fossa, the groin, axillary, inner thigh. So often it's over the thinner skin area. And this one usually is permanent. The purpura, so one of the, I don't have a picture of that. Okay. So one of the skin areas that really gets affected by steroids are the hands and the forearms. That skin is thin anyway, and so what happens, you can see in your paper on the top of page 11, is that wherever they have any kind of bumping or injury, they'll bleed under the skin. It looks terrible, they hate it, and that is not reversible once that starts happening. So the skin will recover, but if they keep bumping it, they'll continue to get those little bleeding areas. If they're on an anticoagulant, it's just worse. If they're taking non-steroidals or aspirin, it just exacerbates it. The other is that fine hair growth, especially on the face. That one is usually reversible. In darker skin patients, if they have had to use steroid on the face, maybe for acne, they will hypopigment over time, and those often they're not always reversible. Most of the time, if you're watching, though, they can revert back, but it can take some time for that to come back to normal. Acne. Acne, this is, sometimes kids, adolescents will figure this out, that you put steroids on acne, it clears up fine, but man, when you take it away, it's with a vengeance and it comes back. You can get it if if you're putting steroid on the face. This can occur with withdrawal. Allergic sensitizations, people tell me, I get sometimes people are telling me I'm allergic to steroids. It's usually what vehicle it's in. It's usually not the steroid. Very uncommon. It's probably very rare, but most of the time I would suspect it's what did we put it in? So it's all the excipients or the vehicle itself. Any questions about those? Okay, so here's another, this one's not as entertaining, but she's really good. This is a dermatologist, and she has made I guess she does a series of these, and she has done this for her patients. But it's really good basic descriptions of the side effects of steroids. She talks a lot about people being steroid phobic or steroid lovers. So she'll tell you that steroid phobic people, you can never get anything cleared up because they avoid it and they won't use it like you told them. Or you got the people who overuse and they have beautiful skin, but then they start getting all these side effects, and she goes through them. It's about 20 minutes, it's a little bit long, but if you're interested, she does a good job, and it's a lot more in-depth. Okay, so we're going to go through this little section here and then we'll take a break. So systemic absorption. So this really does just kind of bring it together and summarize what we've talked about. The strongest ones, group 1, most likely to be absorbed And you see, even with as small as 2 grams a day, now most of these are, that would be a lot. For a lot of these products are like 0.05%, so there's very little in a, even like a fingertip dose. Prolonged use. More than 3 or 4 weeks, you will start getting systemic side effects. Potency, the place where you put it, the thinner the skin, the more likely you are to get systemic absorption. The patient age, the younger the kid, and if you put them in those areas of the body that we talked about, they really get huge absorption. Occlusive dressings we talked about. Penetrating enhancing substances. So we didn't talk about that. The propylene glycol is a vehicle that they will use sometimes in steroid preparations. They enhance absorption through the skin. The other is salicylic acid. Salicylic acid is a dermabrasive. It's very caustic to the skin. We use it in treatment of warts, we'll talk about in the next hour. In acne, they use it as kind of an exfoliant. So that will tend to take off that top layer of skin, and so absorption would be much higher. So that would be what a penetration enhancing substance is. Condition of the skin, compromised liver failure. Or compromised liver function. We rely on the liver to metabolize these drugs. So in your liver patients, they may not be able to get rid of the drug as fast. So increasing the interval between dosing may help there. And then altered skin barrier we talked about as well. Okay. Questions about the steroids? Okay, this will come up